Balancing the collateral ligaments in extension and flexion. So these are the patient details. Male 65 years, varus 14 degrees, FFD 5 degrees. This is the pre-op X-ray. You can see the varus deformity and the posterior osteophyte. Weight bearing full length X-rays, the valgus correction angle is 6 degrees. So the approach is the medial parapatellar approach. Proximal tibia is cut first. Posterior cruciate substituting implants. Ligament balance is checked in full extension and 90 degrees flexion. Superficial MCL is not touched, and 1 to 2 mm lateral laxity is accepted in flexion. So as you can see, it's a partially correctable varus. The first step is to release the anteromedial capsule and the deep MCL. Then the osteophyte, especially the medial ones under the MCL, are removed, which are tenting it. The ACL and the PCL are removed. The medial as well as the posteromedial osteophytes. At this point, the posteromedial osteophytes deep in the intercondylar notch are also removed. And finally, the menisci. So the tibial cut, tibial slope is kept at 3 degrees, as this design has a built-in slope of 4 degrees in the poly. At this stage, the posterior femoral osteophytes are removed after the tibial cut. The femoral cut is decided by the VCA using this jig, which allows variation in the valgus orientation. We use this tensioner from the Orthopilot navigation system. There are 2 limbs in this tensioner, and both the limbs are independent of each other. The extension gap is measured using the tensioner. You can see 19 mm gap on both sides, which is the gap required to accommodate the thinnest poly. Then the spacer block is used to check the extension gap as well as the mediolateral stability. Now important point, the rotation. To balance the flexion gap, the femoral component rotation is determined using the combined referencing technique, using the white side line, epicondylar axis, posterior cut level based on the soft tissue tension, anterior surface and flexion gap using the tensioner. Posterior femoral cut level is marked using the tensioner like this. The anterior surface referencing to prevent notching. Rotation is adjusted using all the landmarks. After this, the 4-in-1 jig is put. This is a slotted jig and the slot is 3 millimeters. Its relation to the previously marked posterior cut level is checked, and the flexion gap with this slotted jig, as you can see, is 16 mm on the medial side, 17 on the lateral, and this is the final check after the cuts, 19 mm medially and 20 mm laterally. Spacer block is used to assess flexion gap and mediolateral stability. So the final ligament balance is extension, both sides same 19 millimeters, flexion is medial 19 and lateral 20. The final post-op X-ray. So the tensioner is a good device to balance the extension and flexion gap, but there is a limitation. It is essential to achieve good mediolateral balance in flexion before determining the level and performing the posterior femoral cut. If there is excessive medial tightness, then we will be putting the femoral implant in excessive external rotation, and if there is excessive lateral tightness, we may put the femoral implant in excessive internal rotation. So this is the algorithm which we use from the book Deformity Correction in TKA by Dr. Mullaji. So excision of osteophytes, release of anteromedial capsule and deep MCL, the first step. If it is fully correctable, then directly TKA. If partially, then further release the semimembranosus and the posteromedial capsule. 10 to 20 degree varus, you may need to add a reduction osteotomy, and greater than 20 degrees, a sliding medial condylar osteotomy. Thank you so much for your attention.